All right, this is my add-on lecture by Patrice. Brian gave an excellent introduction. People always say, but I have a syrinx, I don't have an enlarged central canal. So I went through the literature, and I'll show some papers, but it's not just confusing to patients, it's also, it looks like it's confusing to physicians, and I'll try to make that point. So what we're going to try to learn today is we're going to, two concepts, communicating and non-communicating syringomyelia, and we're going to define the dilated spinal cord central canal, idiopathic syringomyelia, then we're going to go through how to diagnose those, and then we're going to review current medical opinion about the management of patients with dilated central canal, and then we're going to look at how you work up at what's called an idiopathic syrinx. All right, Dr. Miller, who was one of the first people on the scientific advisory board here, he came up with a classification of syringomyelia where if the syrinx is attached to the fourth ventricle, that's called communicating hydrocephalus. If maybe at some point in embryology there was a connection, but it's no longer there, that's called non-communicating because the syrinx and the fourth ventricle, the fluid doesn't go between the two. And then there's another type called post-traumatic where you have a cyst in the spinal cord that's off to one side. So these other types are in the middle, the communicating, non-communicating, and then the post-traumatic is off to the side and doesn't have to connect up with what's called the central canal in the middle of the spinal cord. Okay, so let's get right to it. The first description of what we'd call now is the enlarged spinal cord central canal was by Langston Hawley and Ulrich Batzdorf. And they had seen a lot of what they called slit-like syrinx cavities, and they called them a persistent central canal. And this was from 2002, and it's still controversial, so it hasn't been settled since their original paper. But their original paper, they had 32 people, and they had symptoms like this: spine pain, pain in one small area, some unusual sensations, some muscle spasm. 12 of the people, when they examined the patients, they were normal, and the people who did have problems, they were considered minimal, either with sensation or with movement. And the syrinx cavity was, on the average, 2 millimeters, but it ranged from 1 to 5 millimeters. And there were cervical only, thoracic only, and some had both cervical and thoracic. And they followed these people for about 3 years. And so this is what we're talking about, this little white streak down the middle of the spinal cord. And here's on the thoracic spinal cord. You see, this is spinal fluid on the outside, and this is fluid in the inside of the spinal cord. And this was considered a syrinx before this paper, and they said, well, maybe it's not a syrinx. Maybe it's just that normal structure in the middle of the spinal cord, just a little larger than normal. So as I said, they followed the people, and at the end of about 3 years, 6 of the people had improved on their own, 19 were unchanged, and 7 were worsened. No syrinxes changed in size from their opinion. And the medical workup in half the patients found another reason for them having this central canal. There are other neurologic diseases. So, everybody thinks, well, I found this, I need a diagnosis right now. Well, sometimes it takes time for the underlying condition to present itself. So their conclusions were that these cavities weren't really syringomyelia, but they were just remnants of the central canal, a normal structure. And they said most of the people are asymptomatic or mildly affected, and they're unlikely to change in size. But if you wait, sometimes you'll find out other reasons that people have these central canal. Okay, so just to summarize, the other thing that's been found, like with quote-unquote real syrinxes, they have round ends, but these enlarged central canals, they have tapered ends into the central canal. And it's like enlarged central canal is like a big nose. It's not a disease, you know, it's different, but it's not a disease. In some cases, you can breathe better with a big nose, you know. But still, I mean, if you had your choice, maybe you wouldn't want one. But anyways, it's just because it's larger than normal doesn't mean a disease will result. And a lot of these people, they'll have a syrinx in the neck, and their complaint will be like in the torso. So you can't really relate part of the spinal cord to where they're having symptoms. So surgery is not recommended for this condition because people don't progress, and actually no treatment is better than surgical treatment in these people. Now, the other thing that I found out studying these is if you do cine ultrasound, or cine MRI, there's no fluid motion in this type of syrinx, where with a regular syrinx, because it distends the spinal cord's a little softer, and you will see fluid motion. The other thing with these is if you look at the spinal cord, it's really not distended like you would see with most syrinxes. Okay, and we went through this. People ask and they say, well, how do you know it's not, my enlarged central canal is not causing a problem? But they might have one up in the neck area, which if they had symptoms here, I'd say, okay, well, maybe it's connected, but they'll have an enlarged central canal here and they'll have some symptoms down here, so it doesn't really make sense. They have the wrong part of the spinal cord involved. All right, so let's get back from me just talking and go back to some scientific literature. So at the University of Michigan, when they had radiologists look at MRI scans, this is how they broke down the scans. Chiari, idiopathic, spinal, tumor-related, tethered cord, traumatic, Chiari 0, we'll go into that. But see, the radiologists, they're diagnosing at 31% of the time. However, these idiopathic that they were diagnosing in this study, they were very narrow. They were about 4 millimeters in diameter. Batstorff's average was 2. So the average was a little larger here. Whereas if somebody had a Chiari, the average was almost 8 millimeters. So the Chiari syrinxes were larger. The other thing is their location. Most of the idiopathic were in the thoracic spinal cord. Most of the Chiaris were in the cervical spinal cord. But so their numbers, the 31% idiopathic, really doesn't, neurosurgeons don't see it that way. I mean, they think that most of the problems are from Chiari or basilar invagination, or from arachnoiditis or spinal deformity. And they would say that only about 4% are idiopathic syrinxes. So the difference between 31% and 4%, those are the people who have the dilated central canals. And but as you see, in the medical community, we're not speaking the same language, the radiologists and the neurosurgeons. Okay, so here's another article. And this is from Birmingham, England. It was where Bernard Williams was. They really specialize in syringomyelia. And so it was published in child's nervous system. So they report treating idiopathic syringomyelia. So they had 28 pediatric patients, minimal of 3 years follow-up. So they said 27 out of 28 were conservatively managed, and 1 out of 28 underwent this operation. Well, that person didn't have idiopathic. This person had syringomyelia from a cause. So they couldn't help themselves. They had to include somebody with a cause in idiopathic just to make it more difficult. But anyways, call these syrinxes, call them dilated central canals. Patients in their hands, they said that a lot of the patients had a reduction in syrinx size during follow-up, even though they didn't perform any treatment. So again, no matter, okay, here it is again. So the syrinxes weren't very large. This was one of the larger ones, but didn't really distend the spinal cord. And here's the one they operated on. This one, you can see this is different. The syrinx is larger, has round ends, and they found the culprit. They found a block there in the spinal fluid. Okay, so I think that most of the cases of idiopathic syringomyelia in this study were actually enlarged central canals. But be that as it may, people did well, no matter what you call them, with the follow-up. You see here, here there's a lot of follow-up here, and the patients didn't get worse. Actually, some improved. So no matter what you call them, narrow syrinxes or enlarged central canals, they have a good prognosis. So this is their whole group. They had 18 of their patients, symptoms unrelated to the syrinx. 6 had back pain, 2 urologic bladder problems, back pain and urologic, and 1 neurological. And the clinical follow-up, you can see they were all improved or stable. And radiologic, all the syrinxes were stable, or enlarged central canal, whatever you want to call them. And so you shouldn't treat that condition. They're not going to do better with surgery. Okay, so that's the enlarged central canal or small diameter syrinx. However, if you have a larger diameter syrinx, which is over 5 millimeters, it's probably a problem. And so there's an algorithm for the management of idiopathic or refractory syringomyelia. And so here you go. You start out, you have a syrinx, you get brain MRI. That, you see like the top of the syrinx or whatever, and then you have to follow that up. You get imaging of the whole spinal canal. And then you say, did I find an underlying cause or didn't I? And if you did find the underlying cause, you treat that underlying cause. Like if you had a Chiari, you would treat that. If you didn't identify the cause, then you go to Cine MRI, and you can sample CSF and serum. And then, if you identify the pathology, you treat the cause of whatever was causing the syrinx. However, if you still don't know, then you follow this. Then it's truly idiopathic syringomyelia. If they have very few symptoms, then you have conservative management. You watch them, and but if they're progressive, if they're getting worse, then you treat arachnoiditis, you do a duroplasty, you put it in a shunt, or somehow drain the syrinx fluid. So I think this is how most neurosurgeons would manage the condition. And these algorithms are established because with time, people figured out that most people do the best following that type of algorithm. Okay. So in one of my slides, I talked about Chiari 0. And Chiari 0 is minimal consular ectopia. So you don't qualify for having a Chiari 1. You don't have 5 millimeters, but you have a cervical syrinx. So if you have that, and if you treat the Chiari 0 just by doing the usual Chiari operation, the syrinx will go away. And Dr. Houghton, he looked into this and he said that, well, even if you have just a little bit of tonsillar ectopia, if you have narrowing of the upper part of the spinal canal, you can see this is the blue, that you're more likely to develop a syrinx. So if somebody has a cervical syrinx like this and just a little bit of tonsillar herniation, then you would get the Chiari operation, even though it's not quite a Chiari. This was a man that I saw, and he was referred. He said he didn't want to get a shunt, and so he came in with this scan, and right at the bottom of the scan, there was a sort of indentation, and we worked it up, and we found out that was a cyst that was pressing on the spinal cord, and then at surgery, it was an arachnoid cyst, and we took that out. So this is ideal, like a cyst, no scarring, it's just a mass. So you take the mass out, and the mass that was causing the syrinx will go away if you take it out, because the mass was causing compression of the spinal cord, a block in the spinal fluid, and the syrinx to form. If you take the cyst out, then you will reverse the process and the syrinx will go away. And this is the operation, basically. Take out the cyst, and then in this case, we sewed in a graft, and other people might not sew in a graft. All right, there are truly idiopathic. You look at it, it's not really, say, well, maybe this is a Chiari. They look like this. And in those cases, you can put a tube into the syrinx to drain it. And this is the operation. You can either put the tube in the center of the spinal cord, or you can put it in where one of the nerve roots comes out. Depends on how narrow the spinal cord is. There are other causes for idiopathic syrinxes, like spinal cord tumors, cysts, untethered cord syndrome. We'll go through that. There are lots of different types of tumors, but they affect different parts of the spinal cord, and we know where to look for them. Here's a tumor-related syrinx, and it's thought with these that the tumor secretes fluid, the fluid gets into the spinal cord, and then over time, a syrinx develops. So the treatment for this is to take the tumor out, and if you take the tumor out, the syrinx will go away. I don't think anybody here has a tumor-related syrinx. I see quite a few of these glioependymal cysts. They look like syrinxes, but they're a little bit different. You can see this big syrinx here, and here in cross-section, it's almost the whole spinal canal is filled with cysts. And this doesn't show up very well, but this is one side of the spinal cord, this is the other, and then right here's the cyst. And most of these cysts, they don't have a very well-defined cell wall, so you'll never get a piece of it to really do the histology. But in this case, they did have a defined cell wall, and we could see here, this is the ependyma, and this secretes fluid, and this defines what's called a glioependymal cyst. And we looked at some molecules that are involved with secretion of CSF-like fluid in this cell wall. I had aquaporin, which is one of the molecules for transporting water. And the prognosis in the literature is unbelievable for this condition. I mean, you look at how many, there's no recurrences. So if you have one of these, opening it and draining it has a very good prognosis. If you're interested in how they form, there are all sorts of molecules and enzymes in these cyst walls that will act sort of like the choroid plexus to put fluid into these cysts. Another type of it's not an idiopathic syrinx, but another type of condition that can cause syringomyelia is tethered cord, and it's just if you have a tethered phylum, it pulls on the end of the spinal cord. Every time you move, you sort of stretch the end of your spinal cord. And this generally causes a syrinx at the lowest part of the spinal cord. So if you untether the spinal cord, that will treat it. So they said there was an algorithm for treating syringomyelia before. This is sort of an algorithm how syrinxes form. There's the syrinxes that are caused by obstruction of the spinal subarachnoid space, like Chiari and the arachnoid cyst that I showed you, arachnoiditis. Then there are conditions like the spinal cord cysts and the tumors, where you have increased spinal cord fluid production. And then you can also have the communicating hydrocephalus, where some of the fluid comes from the fourth ventricle. But all of the conditions put too much more fluid in the spinal cord that's coming out. So you have a net accumulation of fluid, and that's why you have a syrinx. Okay, so let me just summarize what we talked about. If you have a syrinx, is it a wide syrinx or is it a narrow syrinx? If you have a wide one and it's in the cervical area, it's most likely from Chiari or basilar invagination or something at the foramen magnum. If you have a wide thoracic syrinx, it's probably associated with a cyst, arachnoid web, arachnoiditis, something like that. If you have a narrow thoracic syrinx, probably a dilated central canal. Idiopathic syringomyelia can occur, but it occurs infrequently. If you're deteriorating, you should seek treatment. You might have a Chiari 0, arachnoid cyst, spinal cord tumor. So you want to treat the underlying condition. If you have stable function, you should probably be watched by MRI scans. But if you start having neurological deterioration, you can be treated. And if you can't find a cause, you put a hole in the spinal cord. And sometimes you put a syrinx shunt in after you put the hole in the spinal cord for drainage. Okay, so I have a plane to catch, so if we have any time for questions, I could try to answer them. I mean, I'm just saying I'm not going to stay till the end of the session. I'm not saying that I'm going to miss my flight if I answer a question. Any questions? Yeah, go ahead. So
then you talked about low fluid motion in some of them, the idiopathic syrinx. So should your neurosurgeon who reads your report should be able to tell you that?
Well, some hospitals do cine MRI, some don't. And if you've had one done, they should report on it, whether there was fluid motion around the spinal cord or inside the spinal cord.
I mean, it wasn't on the report. I'm just saying that the radiologist, that I thought that.
Well, with cine MRI, it's different from anatomy, the anatomical MRIs, because cine, the fluid down is white and the fluid up is black, unless they reset it. They can set it the other way too, but in general that's the case. And so if the fluid in the syrinx goes from black to white, then it's moving.
Just a question about central canal enlargement. Mm-hmm. Should those individuals be avoiding any high physical, like contact sports, weightlifting, things like that?
If you're quite confident that it is a enlarged central canal, it really shouldn't be a problem. However, if you did have an idiopathic, then there is advice that you could deteriorate with Valsalva, with straining. So it's I haven't looked at your scans, but if it's a 2 millimeter enlarged central canal, I think you're fine with weightlifting. But if it's over 5 millimeters, then maybe not.
I was just going to jump in for the lady asking the question about the cine. I'm a neuroradiologist, so if it was done, it would have been mentioned in your report. So if they don't mention a cine or they don't mention CSF flow in your report, they did not do that type of exam.
I must say for neuroradiology that I don't think that's widely disseminated, that if you have a larger syrinx rather than a central canal, that like a central canal, you don't have CSF flow, but maybe in your literature it is there now.
Yeah, if we just see a mildly dilated central canal, we would not do a cine or recommend it, yeah, because they're so common, actually. So we tend to consider less than 2 millimeters an incidental finding.
Yeah, but it's a little tricky between 2 and 5, what to call it, yeah. All right, well, thank you for your attention. I enjoyed being invited, and I enjoyed the meeting. Thank you.